Welcome once again, everybody. We have Dr. Ogbe now on the call. Dr. Ogbe, just signal if you're ready. We can still give a few minutes for others to join in, but if he's ready, he'll just start the presentation. Thank you so much again for joining in. Dr. Ogbe, let me know when you're ready to join, to start.
Yeah, thank you, Peace. I'm ready. Once you give me the nod, we'll start.
Okay, please go ahead. While we still expect others, you can just start so we don't keep them waiting.
Okay.
So a little introduction. Dr. Emmanuel Augustine Ogbe is our consultant pediatrician, and he's also the childcare lead here at R-Jolad Hospital. And he'll be taking us through this presentation, which is talking about jaundice in newborns, and he'll be addressing some misconceptions and also giving some tips on, how to manage the situation. So, Dr. Ogbe, over to you.
Okay, good afternoon or evening, I should say, everybody, and welcome to this very topical presentation on neonatal jaundice. We hope in the next few minutes, by virtue of some few slides I have here, we'll be able to talk about some things that are central as far as neonatal jaundice is concerned, and then also be making attempts at addressing some of the misconceptions that we have about jaundice and enlighten us some more on the better way to approach neonatal jaundice. Please relax and enjoy, and we feel free to ask your questions at the end of the presentation. Thank you. So, jaundice is actually a medical condition in which the skin and the white part of the eyes turns yellow, and is due to excess of a substance we call bilirubin. It's actually a rich substance that comes from the breakdown of red cells. Naturally, bilirubin is taken care of by the liver, but in the case that if there are situations with the liver, excess of it appears in the skin and in the eye. In the newborn, jaundice is quite common, and primarily is because their liver is immature and is being faced by a large volume of red cell, which sometimes the liver may find it difficult to handle, and as such, it accumulates in the bloodstream and show the newborn on the sclera of the eye, that's the white part of the eye, and the skin occasionally, depending on the level of the jaundice. Usually, by the time the child's the liver begins to mature within the first 10 days, it will be the body is able to handle the bilirubin better, and naturally, the jaundice should disappear. However, many new and expectant mothers have a lot of misconception about this phenomena, and they go about seeking counsel from people who themselves are not really well qualified to give counsel about jaundice, and as such, a lot of harmful practices are meted on the newborn. So we hope by the following slides to address some of these misconceptions and offer better solutions on how this condition should be handled. First of all, the first myth is that every newborn has neonatal jaundice. And this is not completely true. Jaundice occurs in about 60% of newborn. That is, 6 out of every 10 babies will have jaundice. So that means of every 10 babies, there are about 4 that may never have jaundice. And this jaundice, which we call physiologic jaundice in medical parlance, is a result of the large volume of red cell that the immature liver have to deal with after birth. And commonly, it is noticed as yellowness of the sclera and the skin, as I mentioned earlier. The next myth is jaundice in the newborn is a serious condition. If it is really neonatal jaundice, we call physiologic jaundice, is actually not a serious condition per se. It's a part of normal development of the child. We have mentioned earlier that red cell is high, liver is battling to deal with the excess bilirubin that is accumulating in the newborn because of this excess red cell. So as such, because the liver is not matured in the first few days after birth, this jaundice appears. However, as the liver becomes mature over time, is a bit better able to deal with excess bilirubin, and as such, the jaundice will naturally clear. So physiologic jaundice is not a serious condition per se, but is part of natural development of the newborn. The third myth is neonatal jaundice is harmless. In a way, this is like a contradiction of the previous myth. But many people believe these facts and then go to sleep, waiting for jaundice to resolve spontaneously. They are not completely wrong, looking at the natural sequence of events that I've mentioned, looking at if you follow the following events that I've mentioned. However, if there are occasions in which jaundice can go excessively high, and when it crosses some threshold, it could be dangerous to the developing brain and can cause permanent damage to the brain and sometimes hearing loss. So the long and short is jaundice in the newborn, though common and harmless, should also be not be taken with levity. The fourth myth is that sunlight only therapy is needed to treat jaundice. Some people believe that only sunlight is what is needed to treat jaundice. This is actually not true. Sometimes we suggest the use of sunlight if the jaundice is at a low level and there are no risks to the baby. However, the standard way to treat jaundice is to put the baby under special lights in the hospital via a process we call phototherapy. Now, this light is designed such in special way such that they absorb the bilirubin from the child's body and the bloodstream, thereby bringing the count of this bilirubin to the safe level. The process of phototherapy, the genitals and the eyes of the baby are protected such that they are not damaged by the photolight. All right. Now, these are also benefits that may not be achieved if we just put the baby under light. Not to also mention the fact that the phototherapy emits the lights that we use for phototherapy emits what we call LED emission diode, LED, which is devoid of ultraviolet light. Ultraviolet light is a special light that is present in the sunlight, and also other lights like infrared are also present in the sunlight. These lights are actually dangerous to the skin. They actually have the potential to cause skin burns to the delicate skin of the newborn. So in essence, if a light that is not filtered may not be safe for treatment of jaundice as far as the newborn is concerned. However, in the event that sunlight is recommended, probably after we have treated jaundice in the hospital and we have brought it to a safe level, occasionally we may recommend this procedure. So if that is recommended, now it's expected that the child's genitals should be protected, maybe by using the diaper, and also protect the eyes of the child. And then we'll place the child close to the window, not directly under sunlight, so that the glass of the window may shield away some part of the ultraviolet light that have the potential to damage the skin of the child. And this should be done with early morning sun and not more than 15 to 20 minutes. Now, the fifth myth is breastfed babies don't suffer from jaundice. Yeah, it is a well-known truth that frequent nursing sessions can aid elimination of bilirubin. And how it does this is by improving digestion and also optimizing liver function. That way, excess bilirubin is excreted through the stool and urine. In most cases, neonatal jaundice is expected to resolve within the first 10 days. However, in the event that jaundice exceeds the first 14 days of life, we call that prolonged jaundice. One of the causes of prolonged jaundice is actually breast milk, in what we call breast milk jaundice. And this is because of a substance which is not well established in its medical parlance, breast milk, that may cause jaundice that is prolonged, that is staying beyond 14 days. So if the doctor have made that diagnosis, what we tend to do is to stop breastfeeding for the first 48 hours. Naturally, the jaundice level will come down, and after that, we'll introduce breast milk to the baby again. So in essence, it's wrong to assume that breastfed babies don't suffer from jaundice. Yes, breastfeeding enhances elimination of bilirubin from the body, but it's also good to keep in mind the concept of breast milk jaundice, which can affect babies that are breastfed. However, a key point to note also in jaundice as a result of breast milk is that studies have shown that it's never associated with brain damage, even though it can make the bilirubin level to rise to a very high level. It hardly causes brain damage. Now, another myth or misconception, as the case may be, is that jaundice is due to wrong eating habits during pregnancy. This is completely wrong. There is no connection between what mother eats during pregnancy and jaundice that the baby suffers in the newborn. Some also believe that if a baby suffers with jaundice, neonatal jaundice, it may also have tendency to have jaundice later in life. This is completely wrong. The truth is, there is the pattern of jaundice or the causative agent, the mechanism by which jaundice results in the newborn is completely different from the jaundice that we see outside the newborn period. Granted, there are some medical conditions that the baby may be born with that can result to jaundice and eventually can extend into later in life. But as far as neonatal jaundice is concerned, which is essentially physiologic jaundice, is not related to jaundice in later life. It is not a result of a liver problem, but immature nature of the liver. And as the liver becomes better by the day 10th of life and is better able to deal with bilirubin, the jaundice will naturally disappear. However, jaundice in older children or adulthood commonly is a result of a damage or abnormality, a more serious abnormality in the liver, which is not related at all to physiologic jaundice. Now, having talked about these misconceptions and probably address some of them, it's now the next step will be to guide us on how we can better detect jaundice in our newborn. I will start by mentioning that the best way to examine for jaundice is under natural light. That means you either take the baby outside the room where under the sun to look at the baby more clearly for a better observation. That is to say, looking at the baby under the electric bulb light may not give a good or a clear picture of jaundice. Now, jaundice, as it were, first appears on the sclera of the eye. That is the white part of the eye. You first see that the child's white part of the eye starts turning yellow. Now, as the level begins to build up in the body, the next part of the body that is affected is the face. Then it will now involve gradually the neck and then the upper part of the chest, and now subsequently progresses downwards as the level begins to build up in the body. So if you take your baby under the light and you see well after the baby is born, and you see that the eye is yellow, watch out for progression. Naturally, the physiologic jaundice that we've been talking about since should not extend beyond the lower part of the chest. If it is becoming that extensive, it's good to seek medical counsel so that your child will be properly examined, and then we'll also do other tests to ascertain the exact level of the bilirubin. So when your child comes to us in the hospital, there are a few ways we go about in evaluating the child for jaundice. First of all, we'll take good history about the pregnancy, the journey of the pregnancy, and also some events that have happened to the child after birth. That can also give us an idea as to whether if this jaundice is primarily because of the natural process of the newborn or maybe linked to other diseases the mother had while she was pregnant, or activities that were meted to the baby after delivery. So examine your baby and ascertain the level of the jaundice, and then that can actually give us the idea of the severity. Again, in the hospital, we're able to go for that, we'll draw a baby's blood and ascertain the level of jaundice. If by day 1 of life, the bilirubin is as high as 5 milligram per DL, is a red flag. Or if the rate of rise is more than 5 milligram per DL, then it's a pointer that it may not be the natural physiologic jaundice, and that kind of child may need to be further evaluated and examined by way of a further test. Now, there are other tests that we do if we suspect that this jaundice is beyond the normal physiologic jaundice. For instance, we do what we call full blood count. Full blood count is an attempt to look for possibilities of infection. Is that more like a screening test for infection? We also look for sometimes we also do malaria parasite, especially if from the history the mother had febrile illness before the first 1 week of delivery. So chances are that child that is born could also have malaria transmitted while the baby was in the mother's womb. So we also do malaria parasite to be sure baby does not have jaundice. Then there's also another test we call direct comb test. Now, this comb test is just a way of looking at the baby's blood to see whether if baby have antibodies that is capable to destroy the red cells. So if there's a mismatch between mother's blood and baby's blood, this test may be positive and may be a pointer as to what is causing the jaundice. Now, in the event that the jaundice is at high level and may require treatment, there are modalities that we use in treating jaundice in the newborn. Now, the first approach is to put the baby under special light, which we call phototherapy. Once your baby needs phototherapy, we'll admit the baby in our special unit, isolated from older children. We call that the newborn unit or nursery, as the case may be. While the baby is on nursery and is about to undergo phototherapy, there are special materials that we use to temporarily blind the child or cover the face of the eyes of the child. And then we'll also cover the genitals, because these lights have potential to cause some harm to the delicate eyes and the genitals of the baby. So we do that, and we place your baby on the light. While your baby is on the light, we monitor the level of the jaundice from time to time, depending on how high the level is before at the start of phototherapy. In our protocol in R-Jolad, we do this jaundice test at least once every day, where we collect blood directly from the baby. However, we also have specialized instruments in our newborn unit for detecting jaundice. We call that transcutaneous bilirubin. This instrument does not require us to collect your baby's blood. That is a special instrument that can just attach to your baby's skin and can give us a fair estimate of the level of jaundice. So that we can do on the average 2 to 3 times a day while your baby is under the photolight. Now, once the baby has enjoyed phototherapy for at least 2 to 3 days and we are satisfied with a drop in level of the bilirubin to a safe level in which the potential for harm to the brain is minimal, at that point we may discharge your baby. And sometimes we may recommend that we put the baby under filtered light. Filtered light will mean that child does not stay under direct contact with sunlight. That means the glasses or close to the window, place the baby close to the window, shift the light from ultraviolet light and infrared that have the potential to cause skin burns or to the baby. So in that situation, using early morning light for 10 to 15 minutes, max 20 minutes in the morning can suffice to further bring down the levels of jaundice of the baby. And then when we discharge, our protocol will be that within the first week of discharge, we'll also see this child in our pediatric clinic so that we'll continue to examine the child and, if need be, also do further blood tests to further determine the level. Now, there are some occasions in which the jaundice can be very, very high to dangerous level. Dangerous level are the levels that have small potential to damage the child's brain permanently or even cause death in some cases. In that kind of situation, when the level of bilirubin is more than 20 milligrams per dl, we do what we call exchange blood transfusion. In this process, what we try to achieve is to completely exchange your baby's blood with a blood that does not have jaundice through a very delicate and careful procedure. It's a procedure that we have expertise to handle. We have done severally and have been successful. This procedure is life-saving and can be handy where baby have excessively high level of bilirubin. It's not expected that a baby that has been under our care, for instance, in R-Jolad, will come to have this high level of bilirubin that will warrant exchange transfusion, because we are so professional that we check for, as part of our protocol, we make sure before we discharge every baby, we check for this bilirubin by the second to third day of life. And then we'll also give you a follow-up checkup by at least before baby is 1 week. So that way, we're able to detect it before it goes this high. And then in the event that we had noticed any rise in level, our phototherapy machine is very effective that hardly do we get to the point of wanting to do exchange transfusion. However, of course, there are rare circumstances. And when that happens, we do exchange transfusion, and we have been very successful thus far. Then there's also a third modality that requires giving your baby immunoglobulins that have the potential to lower the serum bilirubin. However, this is not common practice in the tropics. Now, what can you do on your own in an attempt to prevent the neonatal jaundice from cascading to a more serious jaundice? The first advice here is that you don't have to panic. Remember that jaundice is a common occurrence in the newborn, and a great number of babies will suffer from jaundice. And it's because the liver is not mature enough to handle the bilirubin. As the baby continues to get older, by the first 10 days, liver gets better in terms of its capability to handle jaundice, and the process, the physiology, and the jaundice naturally would clear. We also advise that you breastfeed your baby often. Breastfeeding your baby often keeps your baby hydrated, improves digestion, and improves liver function, thereby making liver able to handle bilirubin better, and this is flushed out of the stool of the baby and urine. It's also advisable that you know your blood group and your rhesus factor. A lot of time, parents tend to misunderstand or confuse blood group for genotype. Hemoglobin genotype is different from blood group. Well, most of the time, when the doctor will most often ask, what is your blood group? Because there's a relationship between blood group and jaundice, especially the severe ones. Mothers that are blood group O, if they have a baby that is of a different blood group, they are more likely to have the more serious type of jaundice, which we call ABO, jaundice to ABO incompatibility. Again, if the mother is rhesus negative, because a blood group can be plus or negative, apart from being A, B, or AB or O, it could also be A plus or A minus, B plus or B minus, AB plus or AB minus, O plus or O negative or O minus, as the case may be. All right. Now, in the event that mother is rhesus negative, there are steps we can take to protect the newborn during antenatal so that she does not spill the blood into the baby that may make her form antibodies that will be detrimental in subsequent delivery. So it's good to know your blood group and know the rhesus factor of the baby. Here at R-Jolad, we have functionally equipped neonatal units and capable consultants at all of our units. At here in R-Jolad, Bagada, Isolo, and even in Agege, very equipped, and our consultants are always there standby to take care of your baby and give you a good experience to avoid the envisaged complications that may occur from neonatal jaundice. I hope we have been able to enlighten you a little on the concepts of neonatal jaundice, and we have tried to address some of the misconceptions. Thank you very much for listening. We'll now be ready to entertain questions if we have them. Thank you.
Thank you so much, Dr. Ogbe. That was such a beautiful presentation. I know I learned so much from it. I don't know if anyone has any questions. You can signify by raising your hand, or you can type them into the comment section so that I could ask directly. But I have a personal question. Is it possible for parents to, for mothers to prevent jaundice for their newborns? Is there anything they can do during pregnancy that can guarantee, prevention of jaundice in their newborn?
Okay, thank you for that question. Yes, there are a lot we can do. First of all, it's good to know that jaundice in the newborn is more or less inevitable in a way, all right? And that the jaundice that we're talking that is inevitable is the physiologic jaundice, which is due to excess load of bilirubin to the immature liver. That may affect 6 out of 10 babies, all right? So if it is that, there is little we can do in preventing that. However, there are things that can cause a more serious jaundice, like if the baby was delivered before 9 months completed weeks. That's if the baby was delivered preterm, that baby is at a higher risk of having more serious jaundice and than the term baby. All right. So there are a lot of things you can do to prevent preterm labor. That will be coming to antenatal regularly. Make sure your doctor checks you from time when you adhere to your visits. And if you have antenatal medications that have been prescribed to prevent infection and malaria that can cause preterm labor, you take them, and then avoid stressful event activities that can precipitate labor and lead to premature delivery. So these are one few among many things that mothers can do to prevent jaundice from happening. However, in the event that jaundice baby become jaundice after birth, there's no need to panic. Just watch the level and seek medical advice as quickly as possible.
Okay, thank you so much, Dr. Ogbe. So Cyril has a question, so I'm just going to unmute him or her, so they can answer that question. I'll be asked that question directly. Cyril, you can speak now. You can unmute your mic to ask your question.
All right, thank you. This is Ella. Sorry. Please, I want to find out from what time can a mother put her baby out in the sun for the sun therapy? Let's say from what time to what time that is most effective.
Okay. All right. Thank you for the question, Ms. Ella. Yes. Remember, we say that before we can do the sun therapy, it must be for the jaundice that the level is low, not the high jaundice. All right. That needs to be clear. And then we must be careful to provide shield, all right, in what we call filtered sunlight. However, to answer your question directly, depending on where you are in Nigeria, the sun is less intense. For instance, in Lagos, around the time of 8 a.m. to 9 a.m. After that time, sun's intensity start increasing. But in some other parts of Nigeria, like in the north, the sun can be more intense much earlier. So advisably, beyond 9 o'clock, the intensity may not be too good for your baby. All right. And then you don't expose your baby for more than 15 to 20 minutes. And then it shouldn't be under direct sunlight. Somewhere close to the windows, with the windows, but the windows light off, where the sun does not have direct penetration on your baby. And this should also be done only when the level of jaundice is low. I hope that answers your question, Mrs. Ella.
Yes, please. Thank you very much.
Okay, thank you, Mrs. Ella. Okay, so Grace is asking if psychological jaundice leads to pathological jaundice.
Okay, physiologic jaundice. I guess you're trying to say.
Yes, physiological jaundice.
Yes, physiologic jaundice, as it is part of normal body process. All right, and should not lead cascade into pathologic jaundice naturally. And why is it physiologic? Liver is immature and is being faced with high load of bilirubin. But then, in the event that as the liver gets mature within the first 10 days, is better able to handle bilirubin and should clear it. That is physiologic jaundice. However, there are circumstances in which jaundice becomes pathologic. That means it's not likely due to the natural process that occurs in the newborn. If the rate of rise of this bilirubin is more than 5 milligrams per DL every day, it's not likely to be jaundice. That is physiologic. If the jaundice appear in the baby in the first day of life, it's not likely to be physiologic jaundice. The physiologic jaundice that we've been discussing since occurs most of the time by the second day of life, peaks around the third to the fourth day of life, and sorry, it's at the third, fourth day of life. By the fifth day, it starts coming down, and by the 7th to 10th day of life, it is at its lowest level. All right. So if it is outside this cycle, it's not likely to be physiologic, it's pathologic. But outright progression does not occur from physiologic to pathologic.
Okay, thank you, Dr. Ogbe. Sorry, I don't know if I'll pronounce his name wrongly, but NRS Nasir is asking if it is all mothers with blood group O that their babies are at risk of jaundice.
Yeah, thank you for the question. Now, if mother is blood group O and baby has a different blood group from O, the chances for jaundice is higher than it would be if it were otherwise. However, for a mother that is blood group O and her baby is also O, that risk is annulled. So it will not be correct to say all mothers with blood group O are at risk of, or baby of all mothers with blood group O are at increased risk of jaundice. However, in the event that there is incompatibility between mother and baby, yes, there's an increased risk.
Okay, thank you, Doctor. So Oluwatosin has a question. Oluwatosin, I've unmuted your mic, enabled your mic. You can ask a question directly.
Good afternoon, Doctor, and everyone.
Good afternoon.
Thanks for the lecture. So my
Thank
question:
you.
how many times can we do the jaundice test for us to be 100% sure that the baby is jaundice free? Let's say we do the test 2 days after birth and the baby is free. Do we have to conduct it again to be 100% sure, instead of us waiting for us to see symptoms before we can now come back to the hospital and say, my baby have jaundice? That is my question, sir.
Okay, thank you, Oluwatosin, for your question. Very nice one. All right. Now, because of our understanding of the natural pattern of physiologic jaundice, okay, that is why we at R-Jolad have targeted the 3rd day to the 4th day to do your check, because we know this is when it is highest. All right, that is our protocol. We do it on the 3rd or 4th day of life. Okay, now if we check now at that time and it's normal or is within acceptable level, it gives us a good assurance that this is likely physiologic and may not progress to, it's not the bad type. All right, because if it is the bad type, there are levels that we'll see around that time that will give us a clue to the fact that this jaundice, the way it's heading, is actually not the normal physiologic jaundice and we may be more proactive. All right. Now, naturally, if it is physiologic jaundice, by the time we repeat it the 7th day, we shouldn't have it higher than the level that it was on the 3 of life. Instead, it should be coming down. So once we see a downward trend, we can say with good certainty that this particular jaundice is safe at that level. All right. However, there are special precautions that we take. For instance, if when we are interacting with mother and we notice that the first baby have jaundice, then the chances of the second baby having jaundice, if the first baby had jaundice that needed treatment, the chances of the jaundice, if it's present in second delivery, to need treatment is higher than if the first baby did not have jaundice. So in that kind of situation, we may tend to be more proactive more proactive and check a little more frequently than we would do if it were otherwise. Or if the baby was delivered before 9 months, complete pregnancy duration, or if the mother is blood group O and there's a disparity between mother's blood group and baby's blood group, is also a red flag for wanting to check a little more frequently. All right. So I'm not sure if I've been able to answer your question with this enlightenment.
Yes, sir. Thank you, sir.
Okay, well done. You're welcome.
Okay, thank you, sir. I've allowed your mic as well. Petro Stoffman Power, you can ask your question now. Okay, I don't know if he or she's available. Let me allow. My apologies if I pronounce his name wrongly. Aye Benny F Owuwori. You can ask your questions now. Your mic is enabled. Okay, in the meantime, I'll just read out some of the questions we have here. Teresa is asking if every newborn must be tested for jaundice, and if yes, okay, you already answered this question. As what day? Damola Aleyemi is asking that a baby with jaundice was treated with phototherapy, but it got worse. Was that a medical error, or is it possible that phototherapy doesn't work for some babies?
Okay, thank you. Yes, must every baby be tested for jaundice? Well, for precautionary measures, if there is an observed jaundice in the newborn, it is proper to test to ascertain the level, unless if the newborn or the child has access to a qualified clinician that is able to tell based on expertise the level of the jaundice, all right, and can say with confidence that there is no progression, all right. In that kind of situation, we may not need to do a blood test, but access to a clinician around the clock may not be an easy task to achieve, right? So because of that difficulty, the potential risks of jaundice, if neglected, we tend to screen all our babies on the 3rd day of life for jaundice. All right, just as precautionary measures in an attempt to detect early and proffer the right treatment. Now that takes me to the second question. Yes, there are situations where the jaundice can be very high and may defy phototherapy. That phototherapy alone may not be able to handle. That is why when we admit a child with jaundice and have placed on the light, we also go ahead to monitor the level of jaundice. Now, depending on the background disease that is tackling that is causing the jaundice. All right. Phototherapy alone may not be able to handle that. And then exchange transfusion. That's why we have the next option of exchange transfusion. Now, in addition to phototherapy, if the disease causing the jaundice in the first place is because of maybe say a blood infection, and that was not detected and treated properly, the jaundice may persist despite phototherapy. All right. So, in support of phototherapy, that organism or that disease condition that is precipitating the jaundice in the first place have to be taken care of. So, in this particular case, that the defied phototherapy may not necessarily mean that the phototherapy is not effective, but then perhaps the jaundice was very much that needed more intervention, which in this case will be exchange blood transfusion. After which, even if we still do the exchange transfusion, the child is brought back on the phototherapy line. All right. So in essence, phototherapy as a procedure could be rather augmented or made to work better by taking care of the underlying problems that caused the jaundice in the first place. It may not necessarily be a medical error, in all honesty. Right? There are jaundice that can persist, especially jaundice if there's a blood group incompatibility. Maybe mother blood group or maybe it's blood group A, that can cause more serious jaundice for therapy alone may not handle. Or if it's a sort of rhesus incompatibility, mother's is negative for a rhesus factor and maybe is positive, and that causes the jaundice, that can also cause some kind of serious jaundice that will need attempts more than for the therapy. Or if the baby did not come on time, was not detected, and jaundice was allowed to progress for a little while, yes, phototherapy may not be able to handle. We must do exchange transfusion and combine it with phototherapy. Thank you.
Thank you, doctor. I'll just read Chidima's one and then I'll go to the people raising up their hands. Chidima is asking if glucose water can help to clear jaundice in a baby because she has seen a mother use it over time rather than present it to the health facility.
Yes, thank you very much, Chidima, for this very important question. Yeah, glucose water is one common misconception about the treatment for jaundice. To be honest, glucose water, as it were, will not be effective in treating jaundice. Instead, what we advocate is breastfeed again and again. All right. We don't advocate that we give glucose water as a treatment for jaundice. Yes, it may serve as a form of hydration, which will enhance eventual excretion of bilirubin, but it's not safe to just be pumping a newborn with glucose water. We discourage that completely. So we prefer that baby is fed and fed well with breast milk, which is safe and free and natural, right? So we discourage that completely. And then I'll also be quick to mention here also that some people have the practice of giving ampiclos to every baby to prevent jaundice. That again is a wrong practice. One, not all jaundice are due to infection, and ampiclos is an antibacterial that is meant to combat infection. Two, the newborn ability to absorb ampiclos as a drug through the mouth is erratic. It does not absorb it well, so it may not get in the system well to treat any infection. If a baby has infection and needs antibiotic, what we'll do naturally is to admit that baby and give the drug through the vein, not really ampiclos. So ampiclos, I've seen that happen severally. It's not a way to treat jaundice. Thank you.
Okay, thank you, doctor. Petrosov will just go now. Your mic is enabled. Please try and ask your question.
Okay, thank you for this opportunity. I think I should comment that this jaundice is something that it is many parents of newborn, many of us, we have, I think, a wrong understanding of it. And unfortunately, the hospitals, they are not doing well enough to educate us when we have this kind, because most times you just, you are ready to take your baby when, and then they just tell you, no, you cannot go home. And for many of us that want to do maybe naming ceremony and stuff like that, and you have the whole thing, just stop your planning, you are frustrated and all. But the hospitals don't do enough to explain to us, these are the reasons for this and that. So, and having said this, for me, I've had 3 children, all in Jolad, and the 3 of them, they all had jaundice. And from my experience, it was after the 3rd one that I got to possibly factor in that possibly it could be, and then hearing from this webinar that was probably due to my wife being O positive. But then I think another area that we are not looking at is that most of these newborn baby, they don't get to eat in the first day of life, which probably are due to maybe the woman, the mother, they are not lactating during that period. And maybe because we're also promoting no baby food. And of course, no baby food, the mother is not lactating, the baby is not eating. So I think this also contributes to it. When you don't allow the baby to eat in the first day, and then you are saying the mother should be trying to force herself to feed the baby, and nothing is coming out of the breast. So the hospital need to do more in educating mothers and fathers about this jaundice, so that we don't have to be fighting with you. Me, my firstborn, I had to fight with the hospital. I discharged against medical advice. Yes, because I said this is frustrating. After spending a week, and you are telling me it has not reduced, it has not reduced. So I think we need to do more. The hospital need to do more in educating us about it. Thank you.
Okay, thank you very much, Mr. Ola, for your comments. It is well taken, and I assure you, by this is part of it in an attempt to enlighten our parents. And like you have rightly advised, we'll do more, really. We really need to do more. I apologize for your experience for the first baby. And I'm also happy that going forward, you were able to, probably by the 3rd baby, understand the fact why your babies keep having jaundice. Your points is well noted, and I assure you, by the grace of God, as a department in Children's Hospital, R-Jolad, will try our best to better inform our parents to be mothers and fathers too, right from the antenatal classes up until the time they deliver, and probably even up on to when they are with us in the nursery. Thank you very much. Your point is well noted.
Okay, thank you, Doctor. Rosaline has her hand up, or his hand up. Rosaline, sorry, I can't pronounce your surname. Please, you can ask the question now. Your mic has been enabled. Hello, Rosaline. I don't know if you can hear us. Okay. While we wait for her, Sholanke, I think you can ask your question. Your mic is now enabled. Okay. In the meantime, we'll just answer some of the questions that are typed. For 1 minute. Okay. Someone is asking if the use of camphor during pregnancy increases the risk of neonatal jaundice.
Okay. Yeah. A camphor, naphthalene ball, as we would like to call it, yes, can actually increase the risk, especially in children that have low level of certain enzymes we call glucose 6-phosphate dehydrogenase enzyme. It's a particular enzyme that help to maintain the wall of the red blood cell. Okay, now this chemical, camphor, have the ability to tamper with the functionality of that enzyme. So if a mother uses camphor to preserve her baby's clothing, and then that child gets to use those clothing at any time, the chemicals can be absorbed through the skin into the bloodstream and can interfere with the functionality of the enzymes that help to stabilize the red blood cells. So red blood cells can break more than it would for physiologic jaundice, and can eventually tip the child into more serious jaundice. Yes, camphor used in pregnancy or to preserve children's clothing is we advise strongly against that.
Okay. Final question from the comments from the chat. NRS Nasi is asking that she observed that after EBT, the jaundice tends to be high in the body for a few days before it starts dropping. That there is reason behind it.
Yes, it's a very wonderful observation that you have made, Ma. Yeah, the reason is this. Now, after exchange blood transfusion, which is essentially to remove the jaundice blood from the bloodstream of the baby by exchanging the baby's blood completely or to near total, as the case may be, there tend to be a rebound increase in bilirubin back into the bloodstream. The liver tends to release some of the bilirubin that it has kept that have been stored in the liver. This is what accounts for the rise that we see after exchange blood transfusion. And it's part of the reason why, even after exchange transfusion, we put the baby back on the photolite so that any rebound bilirubin that is released from the liver is taken care of by the photolite.
Okay. We don't have many more minutes, so please, Aye, Brian, and Shoranke, please try to ask your questions as quickly as possible. If you have any additional questions, please feel to respond to the emails we'll send to you after this.
Good evening, sir. Thank you very much for your lectures, sir.
Thank you.
My question is umbilical catheterization a must for all babies admitted into the special care baby unit?
Okay, thank you, Ma, for your question. Yeah, umbilical catheterization is not a must for babies in the newborn unit. All right. However, there are special situations in which it's safer to catheterize the umbilicals of the baby. It's a sterile procedure, and that is delicate, that takes an expert hand to do. And as a protocol in our hospital, we need to have indications. That means there must be a good reason why the child must be catheterized. And we don't allow anybody that is not competent to do the procedure. Yes, now some of the conditions in which we catheterize is if the baby was born before 9 months, that's delivered preterm, especially if the baby is very preterm, like delivered at 28 weeks or lower, maybe even less than 30 weeks, it's safer to put the umbilical catheter, which is a procedure we do to access the vein. That way, the frequency of coming in contact with the baby is minimized. All the drugs that the baby needs will be administered through the vein, and the fluids, if needed, will be given through the vein. And if we need to collect sample for investigations, we'll do that through the central line, umbilical catheter, as the case may be. All right. So that way, the chances of getting the baby contaminated is much more reduced. In that case, the benefits of catheterization outweighs the risk in the particular child. And then if a child also will need exchange blood transfusion, the safest method that we have here is to catheterize the baby. All right. I'm going to achieve that procedure. And immediately after the procedure, if we don't anticipate that a repeat exchange transfusion may be indicated, which is the case in some rare situation, we remove the catheter after the procedure. All right. So, in direct answer to your question, no, not all newborn babies that admitted into the newborn unit are catheterized, but there are indications that, like I've mentioned above, for catheterization.
Okay.
I'm hoping that answers the question.
Sorry, doctor. Okay. And the final question from Sholanke Rukayat. Please ask your question as quickly as you can. Any additional questions, please respond to the emails we sent to you and we'll try to provide a response. Hello, ma'am. Okay. One final question. Fortune is asking, what is your take on mango juice leaves? I mean, mango leaves to treat jaundice.
Yeah, thank you for that question. Yes, mango leaves, pawpaw, agbo, all of these are modalities that are used in our environment, are harmful essentially, if any, to the newborn than treating jaundice. All right, they may end up causing more harm. Why? Is because these substances, we are not sure of the level of toxins that are inside some of these substances. And then this newborn, the kidney is not as mature to handle toxins immediately after birth. All right? So we may end up hurting the kidney of the newborn in an attempt to treat jaundice that may even be physiologic. So it's not advisable to use mango leaf. It's not advisable to use pawpaw in treatment of jaundice. It's not advised to use herbal concoctions, more or less called agbo, in treatment of jaundice. The baby have jaundice, seek the help of a specialist so that we can advise and treat you better.
Okay. Thank you so much, Doctor, for such a wonderful presentation. And thank you so much for the answers as well. Thank you to everyone who joined. If you have any additional questions, please, you can send your questions in via our social media platforms, or you can call us as well on our call center lines. You can also book an appointment with Dr. Ogbe at our childcare facility here in R-Jolad Hospital. Thank you so much once again for your time, and we look forward to having you in our next webinar session. Thank you so much again, Doctor. Thank you so much.
For having me.
Bye, everyone.
Bye.